oftentimes from women from 45 to 55, if it's a new symptom, I think you need to think very hard that this is related to a hormonal change.
This is Sick Health with Kevin Ban, MD. Our show helps you navigate our confusing healthcare system so you can take control of your own health. Hi, everyone. Today we have Dr. Kristy DeSapri, who came back to talk to me about menopause. Now, we did a real deep dive into bone health and muscle health, but we got feedback that it would be helpful to see the overarching picture about menopause and how to differentiate it from perimenopause, how to treat it. What about hormonal replacement therapy? So today we had the opportunity to go into all of those things. Now, before we get started, the best way to support the show is to subscribe to my YouTube channel, Sick Health with Kevin Ban, MD. Okay, let's get into it. Kristy DeSapri, thank you so much for returning to the show. The last conversation was wonderful. We got deep into bone health, and then a bunch of people said, hey, why don't you guys go after the big topic, the whole topic, menopause. So thanks for coming back.
You bet. Excited for our conversation, Kevin.
Before we get started here, let's remind people a little bit about your career, where you started, how you navigated towards menopause and women's health, and then we'll get into some of the more specifics.
Yeah, absolutely. So I started my career in OBGYN, delivering babies, seeing women of reproductive age, and quickly realized that those women after their reproductive years, really there was a lot of missing information and a lot of work that needed to be done in that area. So I switched my career to internal medicine, staying focused on treating women's care, and did a fellowship in midlife women's health at the Cleveland Clinic, which was really a multidisciplinary area of study looking at women's gynecology, urogynecology, breast health, bone health, what we talked about last time, and also how to manage those menopause and perimenopause areas. This was back in 2010. After that, I was at Northwestern and I was working with a private GYN practice, really helping marry internal medicine and gynecology for many midlife women. I was so fortunate to work at that esteemed practice and then joined the faculty at Northwestern, where I was at the Center for Sexual Medicine and Menopause. And then hinging from my experience of academic medicine, really then went on to start my own practice, which is called Bone and Body Women's Health, which is a specialized midlife women's health practice in Winnetka, Illinois, which is just outside of Chicago, and see women really from 30 to, I think our oldest patient in my practice right now is 93. I always say that I've been doing the menopause medicine and menopause management before menopause seemed, cool and hip, which is really exciting for some of us who've been in the field longer. There's more attention to this time of post-reproductive life, more options for women. So I just think it's such a great time to be in this space.
We're starting to hear more about women's health in general, menopause, perimenopause in particular, but it's a good thing because I think it's largely been ignored, overlooked. And it's important because when you think that women will spend over a third of their life in menopause, and then when you tack onto that perimenopause, then this is a large part of a woman's life and something we haven't done a good enough job talking about. So let's start really high. What is menopause?
So menopause is, if you know your Greek, right? Menopause means monthly pause. So what the definition of menopause, really, when we look at this from a gynecology standpoint, that's 12 months without a menstrual cycle. And that's the definition, again, pause of the monthly cycle. However, this is a retrospective diagnosis or a look-back diagnosis. So many women are confused about, are they in perimenopause? Are they in menopause? What are the years post-menopause look like? The North American Menopause Society, now called the Menopause Society, I'm a proud member of that. And that is really a affiliation of academic as well as private practice doctors, ranging from internists, gynecologists, allied health professionals, cardiologists, you name it, really trying to bring evidence-based care to women at this time of life. And so together, we have helped stage some of these areas and these times for understanding a little bit better of perimenopause and menopause.
So what is the specific diagnosis? How do we differentiate between menopause and what's considered perimenopause? So What do those definitions look like?
There's really no one symptom of menopause. And oftentimes we look at perimenopause and we look to the menstrual cycle to tell us. So in perimenopause, there's two stages, early and late, and there's no flashing light or anything like that that tells us when you're entering these things. But early perimenopause can be signified by your cycle changing. So some women have heavier periods, some people have lighter periods, some start to have cycles getting closer together. So really just a change in the menstrual frequency or pattern. And then in the later perimenopause, menstrual cycles start to sort of spread apart. So every 60, 90 days, and then sort of lengthening out for many women. On average, menopause, 12 months without a menstrual cycle, not being on any contraceptive. We use that as sort of an idea of how close you're getting to the final menstrual period. However, many women, and this is what we'll spend our time talking about, have symptoms of perimenopause and menopause that are actually the same.
What other common symptoms do we see in menopause?
There is no one hallmark symptom of menopause, and this is really what I see in my practice. Some women come with hot flashes, night sweats that disturb their daily activities and sleep and are very bothersome. Other women come with things like brain fog, memory changes, cognitive changes, mood changes like depression or anxiety, things like changes in the bladder, urethra, vaginal tissue causing vaginal dryness, painful intercourse, and even recurrent urinary tract infections. And remember, with the declining estrogen, progesterone, testosterone, this can affect things like libido, also the collagen and elastin that we have in our hair, skin, nails, muscles, and bone. So these are more silent symptoms of menopause, things like joint pain, bone loss. And we know that the loss of estrogen significantly impacts the cardiovascular system. So we'll see things like increases of LDL or the bad cholesterol, increases of vascular resistance, which can increase the blood pressure, and then changes in insulin resistance and metabolism, causing things like glucose intolerance, prediabetes, weight gain, etc. So there's a whole constellation of symptoms that can be really different for each individual woman. I've been practicing medicine for a while in this area. I think that's why a lot of people don't realize that their symptoms that they have are related to either perimenopause or menopause.
I think that's a common theme. Frequently, the diagnosis, if that's the right term for it, often is delayed simply because it's not considered, which really makes you think, like, who takes care of the menopausal woman, right? Like, who is that?
Yeah. Well, if you're asking me, I would say the best people to take care of the menopausal woman are clinicians who've been educated, who are nationally certified menopause providers, but you really have to self-select into that group, right? Primarily, clinicians who take care of women are OBGYNs. The bulk of their training is in obstetrics and deliveries. It's sort of a appalling statistic that less than 6% of all residency programs have menopause education built in. And there's many reasons for that. The amount of hours, the training that's required, the fact that you need someone who can teach you these things about management of menopause, hormone therapy, different options. So I think that's getting better now that we are demanding more. I think women are demanding more. I think the media is helping us push some of these things along, and hopefully medicine will join. For a lot of women, they go to maybe their internist, gynecologist, or some other specialists if they have things like joint pain or frozen shoulder or urinary leakage, and they're going to different specialties to piece together some of these symptoms. And oftentimes, I say from women from 45 to 55, if it's a new symptom, I think you need to think very hard that this is related to a hormonal change.
I think that's really helpful, that a new symptom, any new symptom that doesn't have a clear cause. I mean, obviously, certain things might have a very clear cause. But if you have this new, somewhat squirrely, I'm not sure what it is, then the light bulb should go off that this could be perimenopausal or menopausal. It's necessary to a certain extent to be your own advocate here, right? Especially in today's world of medicine, where oftentimes the visit is so limited. You get in there and the time passes so quickly that you have to be prepared to ask the question, could this be perimenopause? Could this be menopause? One of the big ones is metabolism. How does menopause impact metabolism?
The metabolism piece is a lot of times connected to sleep, right? Sleep disturbance. We know this from endocrinology, from our basic physiology, that when we don't sleep well, those hormone receptors of ghrelin and leptin are affected. It causes us to snack more, have no satiety, and then obviously cause us to be tired and not want to exercise or make good choices. So that is a huge one. Fixing sleep oftentimes can help fix metabolism. Sleep is so important for many other functions as well.
That's one of those things that I've talked about previously on the show. For me, the foundation is sleep because it is so difficult to follow a good diet and to exercise if you're sleep deprived. It's very difficult to do. And then you've rightly pointed out that the impact of sleep deprivation directly impacts neurotransmitters and hormones such that we're more hungry. We crave foods that are not good for us.
Mhm.
We tend to deposit fat more than we would otherwise. So that is the place to start, is
Right.
sleep. I had John Cronin on the show. He's a sleep expert. And we were even discussing, how do you get to the bottom of what causes insomnia? It's important to point out that it could be menopause.
Right. 70% of time when women are getting up in the middle of the night, it is due to hot flashes, night sweats, or sleep changes. And these can be incredibly bothersome. I'm talking up 4 or 5 times a night. I mean, I am shocked daily, but what I hear from women, and I'm always amazed that they're still functioning. So when we decrease our estrogen from our ovary or estradiol, that increases a hormone in our brain called the FSH. When that is continually triggered and we have low estrogen states and it's causing wakings, we also know this is affecting your brain. There's great research in our field called the SWAN study. It's a study of women across nations, which looks at women going through menopause. And those women who have the most hot flashes and the worst sleep have higher risks of things like dementia, cardiovascular disease. So again, this all is connected because we know when women have a hot flash or don't sleep well, that stimulates the adrenergic or sort of fight or flight system, causes vasoconstriction in our heart, in our brains, which means squeezing of the arteries. So we're literally not getting oxygen to our brains and to our hearts. And that is really concerning. So some of my mentors, one of them is Lauren Stryker. I've worked with her for a long time. She's just a great forward thinker. And she says, if you think your hot flashes can't kill you, think again. And so I think it's really important when we think about treatment of symptoms that we don't just say, oh, I'm going to suffer through them or I'm going to keep going. I think they'll get better. It's what I hear from women day after day. But menopausal symptoms as a whole can last on average, 5 to 7 years. And we know for certain ethnicities, like women who are identify as African American or Black, these can last for longer, like 10 or even longer. So this isn't just a 1 year of suffering and then you move on. This can be a large chunk of time.
I think that's a great point that you've made too, that this isn't simply some symptoms that might prevent some sleep and change your mood. These have specific physiologic impact on you and set you up for risk of chronic disease that can be life-threatening. In the absence of estrogen and other hormones, do we see a slowed metabolism?
Both the loss of estrogen and aging really affects our basal metabolic rate. So the amount of caloric intake that we need and our fueling needs does change. The research is pretty solid on this. When we decrease estrogen, we increase our visceral adipose tissue or fat tissue. Most women come to me and say, what is this new belly fat, informally known as like the menopause? And I'm like, well, yeah, so this is shifting and changing of different subcutaneous and visceral fat tissue. And what we're really concerned about is the fat that distributes around the organs like the heart and liver and things like that, which increases your risk for insulin resistance, meaning the glucose that you eat and process is not going to be working well and going to deposit in that area. And then leads again to weight gain and cardiovascular disease and metabolic disease and diabetes and all the problems that when we look around in the United States and world that we're seeing.
I'm going to slow you down and almost stop you there because it's a really interesting and important point, which is understanding exactly where your fat is important. Not all fat is created equally. And you mentioned visceral fat. And that is, again, the fat that encompasses our organs, whether it's the heart, liver, kidneys. That type of visceral fat correlates directly with really bad outcomes like cardiac death and strokes and other very serious illnesses. Now, it's not always clear to people that there are different types of fats. What is the best way for people to understand where their fat is and subsequently to figure out how important it is to reduce fat?
So there are, a lot of options now to evaluate for body composition, which is what you're talking about, looking at lean mass, looking at visceral fat, subcutaneous fat, and these are commercially available more and more. There's also indirect measures of bioimpedance that are available as well to measure some of these. A DEXA scan for body composition looks at those specific areas, certain levels. Having a visceral adipose tissue less than 100 grams per cubed is ideal for that ratio. We look at android to gynoid ratios. These are all, again, ways that we can evaluate the visceral tissue, where the fat is, where there are lean mass is, and work towards those goals of improving it.
You mentioned DEXA scan there. So the DEXA scan itself is an actual X-ray and gives us a lot of information, not only about muscle, but also about bone. You also mentioned impedance studies, which are electrical impulses essentially that are passed through the body, perfectly safe and not as expensive as the DEXA scans. But an impedance scan can also give us information. It is also more affordable and often easier to get just, by kind of Googling it and going out into your community.
Correct. Yep. I would say exactly. I'm just lucky that I have a DEXA scan here in my office. So I do bone density primarily and use the DEXA for what the initial use was for, is that's for assessment of bone mineral density or fracture risk. And take a deep dive into our prior conversation. And this is one of the symptoms of menopause that is often overlooked or quote unquote silent. Similar to changes like in the genitourinary syndrome, like changes in the vagina, vulva, urethra, bladder that sometimes are a little bit more subtle. Bone health has no symptoms until you have a fracture or until someone does a DEXA and says, wow, your bone mineral density is 2.5 times lower than adult peak, or you have a significant bone mineral density decrease that increases your risk for a fracture. And so this is one that I think is extremely important. We talked about when that DEXA should be done. And primarily, I would say at the time of the menopause transition for most women, this should be done just because there are a myriad of risk factors to cause bone health losses and bone density losses, including being a cisgendered female, having ovaries, and going through menopause.
I think you said last time when we discussed the right time to get a DEXA scan and to really have a good understanding of how your bone density is was around the age of 50. Mm-hmm. Does that sound right to you? Is that what you're recommending?
Yeah, exactly. So between 50 and 65, I think in the 60s, that's too late. And if you have risk factors like being female, postmenopausal, a family history, any medications or medical history that contributes to a lower bone density, like a vitamin D deficiency or an autoimmune condition, all of those would really warrant having a DEXA at menopause or midlife. The natural age of menopause is 51 and a half, and that's what we see in the United States. But 1% of women have menopause before age 40. That's called premature ovarian insufficiency. 5 to 10% of women have menopause between 40 and 50. So there are various gradations of when the menopause occurs. We're not even talking about women with cancer, with chemotherapy, radiation-induced or medication-induced menopause, because that shuts down the ovarian axis.
One of the things that you made clear in our conversation last time about bone health, and I will just mention parenthetically that if you wait until you're 65, frequently Medicare won't pay for a DEXA scan. Some insurances won't pay for a DEXA scan until that age, unless you have one of the conditions that you mentioned earlier or family history. So what are your recommendations to women in order to pay attention to bone health and to set themselves up to maximize bone density?
I love this question. This is something that we need to talk about across all aspects of perimenopause to menopause. I mean, this is a total body experience, right? What do we need to do before this time of menopause? There's no what to expect when you're not expecting, book out there or handbook or anything. And I think a lot of it is prevention, which medicine, as we both know, is not so good at. We're better at treating disease than we are preventing disease. So it's things like, for bone health, getting enough calcium, whether that's in diet or supplements, vitamin D, doing some resistance exercise, moving your body, thinking about what is your menstrual cycle? Do you need still a contraceptive? Are your periods very heavy and you're developing iron deficiency anemia? How about getting your pap smears, your routine mammograms, checking your blood pressure, your cholesterol, all of those things? Because what happens, I see, and we see a lot, is that women then come to perimenopause or menopause behind the eight ball, let's say, right? They're like unsure what to do, what to recommend. Maybe they're behind in some health screenings. And then all of a sudden it's menopause. And that can be hot flashes, night sweats, weight gain. Now you need your mammogram. Oh, you might need a DEXA. I mean, it feels a little bit overwhelming. So I think this is why these podcasts are so helpful, and just education in general, because we do need to do things before the perimenopause and menopause to sort of equip ourselves well. And I think we need to be prepared for this more than fear it.
I'd really love to get into how to manage menopause. Specifically, we need to talk about hormone replacement therapy,
Right.
HRT, which has been luckily and recently made more available to women where previously it had not been. We'll get into all of that and more after the break. C2 Sense is doing important work with its Halo platform, applying technological advances in chemistry, machine vision, and material science to provide both patients and providers with laboratory-level accuracy at low cost when they need it. The pandemic reinforced the importance of being able to test in the privacy of your own home. C2 Sense's goal is to use their patented technology to ensure the same quality of testing you would find in your doctor's office in the comfort of your own home. So if you're suffering from upper respiratory symptoms like cough, sore throat, nasal congestion, or a headache, keep your eyes out for C2 Sense as they're developing tests targeting upper respiratory conditions such as COVID and flu. If you want to learn more, see what they're up to at haloreader.com. Kristy, cancer can impact menopause and provoke an early menopause, specifically breast cancer, but other cancers as well. Do you see patients who have gone into menopause because of a cancer?
Absolutely. So this population is really important to identify and to talk with, because oftentimes with a cancer diagnosis, there are a lot of to-dos, right? You're seeing the oncology team, you might be seeing a surgical team, the radiation team, and there's a lot of outcomes and impacts from the treatments that we give, like chemotherapy and radiation. And oftentimes that induces an early menopause for women in their 20s, 30s, 40s. And if we lose our menstrual cycle, a very important vital sign for women, that signifies that there's a decline in estrogen, and that impact is felt across the body from cognitive, bones, genital tissues, etc. And so these women often in their 20s and 30s are pushed into an early menopause where their other cohorts and friends are trying to get pregnant or using birth control pills. So it's a really important time to find someone who understands about menopause or work with your oncology team. When women have early menopause, whether it's surgical or chemotherapy or just natural early menopause, that impacts long-term on increases of osteoporosis, increases of dementia, increases in cardiovascular disease, stroke, heart attack, and muscle loss. I mean, these things are very pervasive. So really does require the use of a network and a team approach to really talk about that hormonal piece, in addition to all the other things that are going on with treatment.
This is a great point. You're in your 20s, you're in your 30s. The last thing that you're thinking about is that you may develop menopause as the result of a treatment. It's an important shout out because I think it's going to have a very long-term impact on you. So how do you manage? What's the best way to approach the management?
Get the appropriate screenings that you need. Talk about your symptoms. I think sometimes these are less identified symptoms. So, in the case of breast and ovarian cancer, hormone therapy or hormone replacement therapy is not indicated for these women. However, we do have non-hormonal options that can help with sleep, hot flashes. We do have vaginal preparations that can help with vaginal dryness or painful intercourse. We do have options for these things. I think the plan is just suffer or be happy you're alive. I mean, I have heard this from many patients before, and unfortunately, these symptoms don't go away, and they're dealing with a massive change in their hormones and in cancer and the treatments that surround that.
You mentioned non-pharmacological, let's say, treatment of menopause. What about herbal approaches? There are people that ask about vitamins, diet, and then herbal preparations. Where do you land on those?
Yeah. So I come at menopause and medicine from an academic standpoint, even though I've worked in big hospitals and I'm in academic centers and in private practice, and I'm a member of the Menopause Society, which we really do follow the evidence. As much as I'd like to say some of the over-the-counter preparations containing things like black cohosh or valerian root or chaste berry, etc., help, when we look at meta-analyses or large studies of these products, that they have a very strong placebo effect, meaning they might work for a little time and then they stop working. And the placebo effect can be like almost about 30 to 40%. So you might feel a little bit better, but again, those tend to wear off over time. The same is true with products that contain things like soy. Potentially, some women might convert that soy into an active estrogen metabolite and help, but it's very rare to do that, especially women living in the United States. And so the Menopause Society really puts out these position statements on the use of hormones, the use of non-hormonal options for peri and menopausal symptoms. And this was updated actually just last year. If you're looking for more information, that's a great website to look at, menopause.org. Unfortunately, a lot of these herbal preparations really have a strong placebo effect with no lasting effect on things like hot flashes, sleep disturbance. Things that have been proven that are non-hormonal options are things like paced respiration or even acupuncture. So things like deep breathing and acupuncture might be helpful. Again, when women are having moderate to severe hot flashes or sleep disturbance, I'm not just going to go tell them to take a couple deep breaths, right, and hope that it goes away. I think that's not something we want to do. Thankfully, with this field evolving, we have some pharmacology, some options now that are non-hormonal options. Some are based in the class of SSRIs or selective serotonin reuptake inhibitors. There is one that's FDA approved, others that we use off-label. There is a whole new class of medicines that work on something called the NK3 receptor antagonists, which are receptors in the hypothalamus of our brain that actually impact our sensation of a hot flash and really downregulate that sensation. And so those are some new classes of medicines that are out there. One's FDA approved and one is in the pipeline. So those are helpful options as well. And then we have another option that can be used that helps with overactive bladder that can also help with hot flashes and night sweats. And there is even a procedure called a stellate ganglion block that actually is a injection into the neck that affects the parasympathetic nerves, can actually downregulate the hot flash sensation. So we have a lot of options there for those symptoms that are non-hormonal, that have been FDA approved, looked at, and cleared.
So you just brought up the non-hormonal. I think it's time to talk about hormonal replacement therapy, HRT. That is something that, because of a study in the early 2000s, and I'd love for you to take us through that study and how it was interpreted 24 years ago, or over 20 years ago, I should say, and how that has changed such that now HRT is being recommended in the right patients more frequently.
Yes. How long do you have, Kevin? No, I'm joking. So we have, so let's, remember that the first estrogens were FDA approved in 1940. So we have a long span of use of estrogen containing contraceptives and also hormone therapy. Primarily, when we had those FDA approved, those were initially things like Premarin, which is conjugated equine estrogen, which is estrogen created from the urine of pregnant mares. And it's 9 different estrogens sort of mixed in together. And up until the 80s, 90s, et cetera, that's the only estrogen we had around, and that was being studied. And actually, even before the WHI, that one landmark study we're going to talk about 40% of women in the United States were on hormone therapy because studies were reassuring in terms of this was going to be helpful for cardiovascular disease or prevention of chronic diseases. And so we had a lot of evidence showing the positive. What happened with the Women's Health Initiative study really has changed, as you mentioned, our prescribing patterns, but also just the knowledge about hormones, the treatment, and also just a large gap of time for medical education and treatment for women of this age. And I think this is why finally menopause is kind of having a moment or swinging back around, that we have some of this data reinterpreted and understood in a clearer way. So the WHI was a large study funded by the NIH looking to see if hormones in women who are on average in their 60s, so on average 63, and so further from the menopause transition by about a decade or more, if estrogen, which was conjugated estrogen, and Provera, which is Prempro, known as, or just estrogen alone, Premarin, could prevent heart attacks, heart disease, diabetes, cancers, etc. So it was really looking primarily at the cardiovascular disease. By design, they didn't include women who had hot flashes or menopausal symptoms, because then they would know that they were on the active treatment and not the placebo. So this was not a study to help us determine if estrogen helped with menopausal symptoms. We knew that it did that. And so it took, 27,000 women, and some women who had a hysterectomy and other women who had not, and then randomized them to estrogen alone or estrogen plus progesterone versus placebo, and followed those women over 5 to 7 years. The study was halted early in both arms, the estrogen alone arm and the estrogen plus progesterone arm, for various reasons. The estrogen plus progesterone arm was halted for the increased risk of breast cancer that was seen after 5 years. And the estrogen alone arm was discontinued early for the concern of a stroke that was increased after the 5 years of use. And these women were all aging during the time. And what was heard across the world was that there was increased risk of breast cancer and stroke and heart attack, and everyone should be pulled off of their hormones and flushed down the toilet. When we pulled back the veil and reanalyzed a lot of this data, it looked like women who had been on estrogen or estrogen plus progesterone really actually had quite a few benefits: reduction of things like diabetes, osteoporosis, hip fractures, other fractures, decreased risk of their menopausal symptoms. We sort of realized as well, looking at the different ages of women in the study, cohorts of women between 50 and 60 versus women who are 60 to 70 or 70 to 80, that the use of hormones and the risk-benefit profile really should be looked at and adjusted. So women who were starting hormones less than age 60 and within 10 years of menopause, the benefit actually way outweighed the risk for all the things that I just mentioned. And there was actually a decreased risk of heart attacks, a decreased risk of cardiovascular disease, a decreased risk of osteoporosis, diabetes, and chronic medical diseases as well. The healthy cell or timing hypothesis. When we're thinking about prescribing hormone therapy, we have to do it at the right time in the right woman without any contraindications. And that's really evolved over time. We've reanalyzed this WHI data time and time and time again. And these women have been followed over time, even though the study was a small snapshot. Most women come to me very fearful that estrogen causes breast cancer. But when we look at the data, that increased risk of breast cancer was one additional breast cancer per 1,000 women over 5 years. So one additional case per 1,000 women for every year of use. And when we look at estrogen alone, there was no increased risk of breast cancer. So very interesting, but that point sometimes gets missed. Why women think that estrogen causes breast cancer is because the relative risk, or the risk of being on nothing compared to being on estrogen, was touted as 30, upwards of 27 to 30%, which in a lot of people's minds sounds very scary. We know that 1 in 8 women will develop breast cancer if they live until 80, and that breast cancer is one of the more common cancers that we see. However, the correlation and the causation of estrogen with hormone therapy with breast cancer has really never been established. And so this is a very complicated interplay.
So it sounds like those data from 20 years ago were just largely misinterpreted because of not bracketing it into different age groups. And when you actually parsed out the age group into women in their 50s versus women in their 60s and 70s, then HRT actually drives better outcomes in terms of heart health, in terms of bone density. What do you recommend to women when you evaluate them? When are the moments when you would say, no, this is not a good option for you versus a great option for you?
The most important, actually, when we think about hormone therapy, it's really important to individualize risk, benefit, understand the differences. If women have had a history of a breast cancer or ovarian cancer or an estrogen dependent cancer, we do not prescribe hormone therapy. That is one of the 3 contraindications, the other being an unprovoked blood clot or a stroke or a heart attack or undiagnosed or unexplained vaginal bleeding. This is where really an individualization approach is really important, right? Looking at the woman in front of us, in front of me when I see them, and looking at their menopausal symptoms, talking about risk benefit, really tailoring the dose, the duration, the formulation of both estrogen, progesterone. And of course, we've evolved our thinking into looking at other preparations of estrogen. So things like transdermal or on the skin estrogen, bioidentical estrogen options, which includes things that are similar to what our own ovaries made during our reproductive years, such as estradiol, progesterone, or prometrium, and including testosterone in that mix as well. And this takes some tweaking. The management of menopause, and this is why it's not as easy as a one annual gynecologic visit. It really takes some back and forth, some trial and error, some discussions, some education. Some of my patients come to me very aware and others are not. And so it really takes going back and understanding what are the symptoms, what is your reproductive history, what are we trying to accomplish through the menopause transition, and then finding those right, whether it's hormones, whether it's non-hormonal, whether we tweak lifestyle, we talk about other chronic conditions and sort of working, together. But just having a family history of breast cancer does not preclude you from use of estrogen. We have some evolved medication options and studies that have really shown that certain different progesterones or estrogens don't impact the breast tissue as much. We have observational studies looking forward over time that there's no increased risk of breast cancer seen when we start estrogen in the perimenopause or menopause transition and follow women over time. We absolutely need more studies in this. And this is one of the reasons why women's health research hopefully is getting more funding and is really at the forefront, because we need more answers. And I think this tide is turning and understanding the individualization of, everything we do in medicine. 51% of the population is female these days, and we need answers on this very important time of life.
Kristy, this has been a great conversation. Is there a book that you recommend people take a look at that can go through some of what we discussed today in the podcast?
Yeah, there are a lot of good menopause books out there now written by physicians or scientists. I recommend one by Dr. Lisa Mosconi, who is a neuroscientist looking at changes in the menopause brain. And her book is aptly called The Menopause Brain. And I think it's a great one that goes through the state of, where we are with hormone therapy, understanding changes at menopause, lifestyle, treatment options, etc. So that's one I would recommend.
Thank you so much for joining me a second time. You've been so generous with your time. I really enjoyed it.
Me too, Kevin. Thanks for the engaging conversation.
And I'd like to thank all of you for listening to today's podcast. Do you have any questions, any comments? If so, please let me know. Until next time, be well. This show's content represents my personal opinions. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not create a physician-patient relationship with me. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition or your general health.